We will go for the second subject. Doctor, please excuse me if I spell your name in wrong way. Dr. Izaskun Zeberio. Dr. Izaskun Zeberio is from Spanish. She is complete her residency, specializes in hematology and hematopathy in the Virgen del Camino Hospital between 1995 till 1998. And since 2014, she's working in the Department of Hematology and Hematotherapy at the University Hospital of Donostia. And since 2025, she's the head of the clinical hematology unit. Her clinical interests focus on primary of the diagnosis and treatment of lymphoma and lymphoproliferative syndromes, as well as advanced therapies. In 2016, she received the Dr. Bella Lewis Award of the Best Scientific Article published in the Medical Journal from the Foundation of the Official College of Physicians of Gipuzkoa. She is a member of Naravi Hematology Association and the Spanish Society of Hematology and Hematotherapy, SEHH. And she is also part of the Giltamo Lymphoma Treatment Group. Welcome. We appreciate that you are with us, especially with the nurses, as you are ahead of the hematology. Mike is yours.
Thank you very much. It's a pleasure to be in this SSBMT Congress, and thank you for your kind invitation. I will talk about Hodgkin lymphoma. These are my disclosures, and this is the agenda that I will follow in the next 20 minutes. Hodgkin lymphoma is a type of malignancy that affects the lymphatic system and is marked by the presence of red stem cells, which are large cancer cells not found in non-Hodgkin lymphoma. Although the disease originates in the lymph system, the cancer can spread to almost any organ or tissue, including the bone marrow, liver, and spleen. It's a rare disease. It only accounts for around 10% of the whole lymphomas and is the lymphoma with the best overall survival because we are lucky that most of the patients will achieve the cure after the treatment. It's a rare disease. The incidence is around 2 cases per 100 inhabitants. And as I already told you, the cure is very high. And we have seen an improvement in the survival rate in the last years, not seen in another neoplasia. The incidence is biphasic. Most of patients are young teenagers or young adults in their 20s. And also we have another peak of incidence in older patients. Around 20 to 20% of patients are older than 60 years old. Risk factors to develop Hodgkin lymphoma is the Epstein-Barr virus, the age, young age or older people, male being a male, the family history we have, we don't know why, but brothers affected with Hodgkin lymphoma, and the immunosuppression due to HIV or another treatments in solid organ recipients or patients receiving immunosuppressant for autoimmune disorders. For the diagnosis of lymphoma, Hodgkin lymphoma, we need a good biopsy. Usually we need an excisional biopsy because the pathological diagnosis is based on the finding of these red stem cells in the tumoral tissue. It's also very important the microenvironment, the cells that are surrounding these red stem cells, the lymphocytes, eosinophils, neutrophils, and histiocytes that are characteristics of this illness, and this tumor microenvironment supports the red stem cell cells. There are different red stem cell cells. The most common one is the binucleated red stem cell, but also we have in the nodular predominant variant, we have another type of L and H cell that is the popcorn cell. The classification, we have two types of Hodgkin lymphoma. The main one is the classical Hodgkin lymphoma that accounts for 95% of the Hodgkin lymphoma cases, and the red stem cells in this case is the typical one and is positive for CD30 and CD15. There are different variants like nodular sclerosis, that is the type most frequent seen in young people, and the mixed cellularity seen in older patients. There is another variant, the nodular lymphocyte predominant Hodgkin lymphoma, that is only 5% of all the Hodgkin lymphoma, and is totally different. The tumoral cell is the popcorn cell, and the immunophenotype is negative for CD30 and 15, and is positive for 20, is positive for 20, and another markers typical of non-Hodgkin lymphoma. Nowadays, in the new classification, we consider that this variant, non-classical Hodgkin lymphoma, is more is considered a low-grade B-cell lymphoma because all the presentation, the clinical evolution, and the treatment should be totally different. And what symptoms have patients with Hodgkin lymphoma? They usually go to the doctors because they have an adenopathy, a lump in the neck and in the armpit. Usually the adenopathies are rubbery and painless. They can also have a mediastinal mass with cough, with breathlessness, or also with chest discomfort that was lying flat. Due to the inflammatory interleukins and substances that the tumoral cells throw in the patients, they can develop also systemic symptoms like B symptoms, that these are fever, weight loss, and drenching night sweats. They also can have itch and alcohol-induced pain. That is very typical when this patient drinks alcohol. The lungs are induced pain, and they also can develop fatigue. It's very important for the nursing point, the early recognition of these symptoms and prompt referral to these patients. Before we start treatment, we usually do an echocardiogram because they will receive anthracyclines that they are toxic to the heart. We also consider lung function test because these patients will receive bleomycin that is toxic for the lung, and also we have to inform patients and blood bank that they should only receive irradiated blood products. Also, we have to discuss if we are going to give chemotherapy to these patients, fertility preservation in women with stimulated egg or ovarian preservation, and in men with sperm storage. The extension study are made by PET-CT, and the staging system is the Ann Arbor system. It's very simple. Stage 1, when the patient have one involvement of single lymph node region. Stage 2, if the patients have 2 or more lymph nodes regions, but in the same side of the diaphragm. Stage 3, when the patient have involvement of lymph nodes in both sides of the diaphragm. And stage 4, when the disease is disseminated in the extralymphatic disease, like a solid node in a liver or in the bone or in the lung. And we put B if the patients have B symptoms, X if the disease is bulk, that is when you have adenopathies greater than 10 centimeters, and S if the spleen is involved. The nursing role is very important. Is this preparation for diagnosis, for the biopsy and imaging, and also the education on a staging process and expectation with this disease. Most of the patients will have stage 1 or 2 that is considered localized, and 40% will develop advanced stage, that is stage 3 or 4, and this impacts in survival. Patients with stage 3 or 4 have worse survival. I already told you that 20% of patients are older than 60 years old, and these patients have much worse prognosis because the histology and the biology of the disease is different, because these patients don't tolerate well the chemotherapy. They receive lower dose intensity treatments due to the treatment-related mortality, risk of infection and toxicity, and because these patients have also comorbidity that limits the capacity to receive chemotherapy. And they also have an increased risk to develop lung toxicity due to bleomycin. And how do we treat these patients? We usually, in first-line treatment, we use in early stage, we combine 2 or 4 cycles of chemotherapy plus radiotherapy, and in advanced stage, we usually use 6 cycles of chemotherapy. Now, we have the capacity to use new drugs that I will comment on that, like brentuximab or nivolumab, improving especially the survival of patients with advanced stage disease. With this first line, we are able to cure more than 80% of the patients, and this means that we will have long-term survivals, and these patients will live a long time, and they will develop long-term side effects like secondary neoplasia, cardiovascular disease, hypothyroidism, and infertility. The 2 main chemotherapy approaches in first line are ABVD, used more in North America and Europe, and is less effective in advanced stage because it cures around 75% of patients in advanced stage, but is less toxic, and this chemotherapy has lower impact on fertility and the development of secondary neoplasia. The German group uses in advanced stage, especially escalated Biogipuzkoa, that is a chemotherapy that is really effective in curing more than or around 90% of patients with advanced stage, but is much more toxic with a lot of infertility about this treatment and the risk of developing secondary neoplasia. Now we have 2 new options, including chemotherapy with new treatments like nivolumab or brentuximab vedotin for advanced stage, and these are new combination nivo-ABVD developed in North America, and BRICAT, that is like a better BCOP escalated. They take out the more toxic bleomycin and they substitute it for brentuximab and also procarbazine to dacarbazine, and they achieve a very high cure rate with this BRICAT combination with brentuximab and the old escalated BCOP with much less toxicity. The new drugs that we are using in Hodgkin lymphoma are brentuximab vedotin, is anti-CD30 antibody conjugated to a drug, monomethyl auristatin. This antibody is internalized in CD30 positive cells like the Riyadh tumoral cells and causes the death of the tumoral cells. The main toxicity of the brentuximab is neuropathy, and the nurse teams are crucial to detect and adapt the treatment when patients developed neuropathy. And the other drug that is very interesting for Hodgkin lymphoma are the immune checkpoint inhibitors, nivolumab and pembrolizumab. The red stem tumoral cells, they express PD-L1, that is an antigen that inhibits the activity of the patient's T cells. With blocking this PD-L1 antigen with nivolumab or pembrolizumab, then patient's T cells are able to attack and kill the tumoral cells. And as I already told you, the drugs that we use, they are cause of important toxicity that we have to detect and manage. The immunotherapy also causes immune-related adverse events when these T cells attack the patient's tissues, like thyroiditis, pneumonitis, or colitis, and it's very important to use all the supportive care in this patient. From the nursing role, the symptoms control, the patient education about side effects and when to seek care, and also all the support for the treatment adherence is crucial. Most of the patients will achieve the cure with the first time, but some of patients will relapse. When we have the suspect that a patient has a relapse, we have to do again a excisional biopsy, because sometimes you can see that there are alternative pathology results, and also we have a lot of false positive in PET-CT. When a patient has a relapse, you have to restage again with PET-CT, consider fertility preservation, and also seek the input of different specialized services. Around 10% of patients will be primary refractory to first-line treatment, and 20% will relapse. In these patients, we use salvage therapy, usually target agents, again, like brentuximab or pembrolizumab combined with chemotherapy, and we try to consolidate these patients with autologous stem cell transplantation if they are fit and if they achieve a response to the salvage therapy. In high-risk patients, to try to reduce the risk of relapse, we use also brentuximab vedotin maintenance after autologous stem transplant. Some patients will relapse after autologous transplant, and then we have the option of use again new target agents as salvage therapy, and if they have a good donor and if they achieve some kind of response, to try to bring them to an allogeneic stem cell transplantation. We are happy to have a lot of long-term survivals, but these patients have a higher risk to develop respiratory disease, also cardiovascular events and secondary cancers, and also especially the risk of cumulative incidence of heart failure in these patients is very high after using high cumulative doses of doxorubicin, and especially if they are combined with mediastinal radiotherapy. Also, there is a very interesting publication that not only radiotherapy is a risk factor in women for breast cancer, also the high dose of cumulative doses of doxorubicin are linked to a higher risk of breast cancer in survivors of Hodgkin lymphoma. For this long-term risk, is crucial the nursing involvement in the long-term follow-up coordination in the different programs that we have to follow these long-term survivors, in the lifestyle counseling, and also in the different screening adherence. And with this, I would like to finish. Hodgkin lymphoma is an unique epidemiology. It's very common in very young patients, and it has a biphasic incidence, unique outcomes. We cure the majority, but we have to must keep an eye on late effects of the radiotherapy and chemotherapy, and elderly patients remain a challenge, and we have to be very cautious with bleomycin in elderly patients. I think that nursing role is crucial in the different teams, and especially in the whole process in the care of these patients. And thank you very much. I will be happy to take some questions.
Izaskun, I would like to ask you to avoid positive PET scan. As you know, when you do it, sometimes if the patient in GCSF, usually we are trying to avoid to do it within 5 to 7 days, but sometimes some the radiologists, they will ask more than 2 weeks. And also, if radiation, usually we do 2 months, but sometimes some radiology, they ask 3 months. And sometimes if the patient have infection, all of these factors, it will affect to give us a wrong PET scan result. So usually, what is you prefer time, the best time to repeat the PET scan? Of course, after treatment, but to avoid these circumstances. And if the patient GCSF or if he received the TBI, radiation therapy.
This is a very important question because PET-CT has a lot of false positives. We usually, when the patient finishes treatment, we try to have like 4 to 6 weeks before we do the PET-CT. And if patient has an infection, we always we tell them to call us because sometimes if they perform the PET-CT with a respiratory infection, you will have a false positive PET-CT and you have to repeat it. After radiotherapy, we try to at least we have a window of 3 months after radiotherapy, because after radiotherapy we have a lot of false positives. And in the follow-up, we never do PET-CTs. We follow up this patient in the clinic with a blood test and a physical exam and nothing else. And if you are suspecting that the patient is relapsing, then you have to do a PET-CT, but not in the survivorship follow-up.
Thank you so much for your nice presentation. I have one question. What's the recent update has most changed management in Hodgkin lymphoma in your center?
For me, the most important is that we have an amazing nursing group that supports our patients. They follow all the toxicity. They support our patients. They do all the, if we need a PEEK or a vascular access, they follow our patients. And this is the, I think the nurse team support is the main success in our team. Also, we have access now, I as already told you, most of patients will be cured, but this 30-40% of patients with advanced disease, stage 3 to 4, we use in Europe ABVD, and it cures only 70% of patients. Nowadays, we have the option to use Brecad, that is like a better BCOP escalated with brentuximab and with less toxic drugs, and with that we are curing 90% of patients, and this is also it has a huge impact in our patients.
Thank you so much.
Any question? Yeah, she has a question.
Hello, Dr. Iza. Good afternoon.
Hello.
Hi. Dr. Iza, in your years of experience managing Hodgkin lymphoma, you mentioned it's commonly with a young adult. Have you encountered a patient undergoing induction chemotherapy and got pregnant? And that's the first one. Secondly, a patient that has been newly diagnosed with Hodgkin lymphoma but currently pregnant, and what is your treatment plan of action afterwards? As you mentioned, although ABBD have a less impact in fertility, and you do fertility counseling, but I just want to seek your experience as compliance-wise. I don't know the people in in your area might be more compliant when it say, do not get pregnant. We have a different set of patients here that sometimes it happens. They do get pregnant even if they advise them to be in contraception or something. Thank you.
This is a very important question. We are lucky because we don't have too much patients that become pregnant during treatment, but this is a drama, of course. We try to educate our patients, but sometimes you have, these are young people and they get pregnant, and this is a huge ethical issue. If it is in the first 3 months, you cannot give any chemotherapy and you have to avoid also radiotherapy. And if it's a localized stage, we give the option to the patients to wait. If the patient is in a good shape and it's a localized disease, we try to wait some months and try to avoid the treatment until the pregnancy is advanced. You can give chemotherapy safely, and there are and also delivery the babies inserts period of from 6th to 9th month of the pregnancy, and ABVD is safe. I have never done that. And if patient is in the first 3 months and has an advanced stage disease, it can compromise the life of the patients and also the life of the baby, and that's why in the first 3 months, if the life of the patient is in danger, we talk about abortion. But this is there are good reviews about how to treat this patient, but this is a drama. And I have had a patient who was already pregnant in the 6th to 9th month of the pregnancy, and she was diagnosed with Hodgkin, and we wait until the delivery and then treated her. But I am very lucky not to have patients getting pregnant during treatment, but this is reported and it's very important.
Any more questions? Thank you so much, doctor. We appreciate, really, it was an honor to have you with us.